Thank you for the kind invitation. So my presentation is on how to implant the reducer and what to expect in terms of outcomes. There is a lot of talk in interventional cardiology after some big trials about when to revascularize in stable ischemic heart disease. Until now, the robust data is that we revascularize for sure for symptoms, and in some cases so for prognosis. So until now, in patients that we see in the cath lab registries, we see that around 6 to 10% of patients are coming with ischemia and are ineligible for revascularization. And these patients still have symptoms of angina. I will go directly to the topic, to the reducer implantation. Until now, we have some data that this device improves angina symptoms in patients with refractory angina. So in the guidelines, we have a 2B indication for patients with refractory angina ineligible for other revascularization strategies. So what is coronary sinus reducer? It's a device having an hourglass shape that is implanted directly in the coronary sinus, aiming to induce a stenosis of the coronary sinus, and we've seen that this relieves symptoms of refractory angina. This is the device. We have a pre-mounted device on a balloon catheter. We have a guiding catheter of 9 French, and a hemostatic valve, and we use mainly a high-torque supportive wire or a mother-and-child technique in order to implant the device deeply in the coronary sinus. This is the device mounted, and this is when we inflate the balloon. And here are what we aim. We aim for a safe access from the right jugular access. We have to be correct in the implantation site, not very deep and not in the coronary sinus ostium. We have to use a stiff wire like the supracore or to use mother and child technique in order to avoid some complications of reducer immigration. We have to achieve a device oversize depending on the coronary sinus size, and at the end, the most tricky part, to have a safe balloon retrieval. Here is the steps that I presented previously. And we will see the videos in some cases later. So now, when to implant? The only established indication until now is in refractory angina. And we say refractory angina in patients suffering from angina under optimal medical treatment, and that doesn't have any other revascularization options. Mainly are patients, previous CABG patients, not eligible for reduced CABG, or patients that are in very high procedural risk for a PCI or reduced CABG. There is another patient group, the ANOCA patients, that we've seen some promising results until now. And with some question mark, because we don't have robust data, we may implant it in the future to reduce ischemia. So we'll see some cases. This is a procedural challenging case. It's a 77-year-old man with previous CABG, around 20 years before, with all saphenous vein graft closed and a patent lima in the LAD. He has chronic kidney disease and an ejection fraction of 45 and has refractory symptoms despite maximization of the therapy. The SPECT shows large reversible inferolateral ischemia, and the diagnostic catheterization shows 2 CTOs. CTO of the circumflex, CTO of the right, not of the circumflex, sorry. A patent lima in the LAD, and the right coronary artery that has multiple 10 times before PCIs with failures of the PCI. It has too many restenosis, this patient. So, but the ischemia seems to be from the obtuse marginal and the circumflex artery. This patient has poor targets. He has contrast kidney disease, so it's not We don't want to do a procedure with too much contracts, like a CTO PCI, and has 5 previous restenosis with PCI in the RCA. So we considered him eligible for reducer therapy. We catheterized the coronary sides with a multipurpose catheter. We had the procedural difficulty to advance the guiding catheter because a very thick coronary sinus valve. We tried to pass this valve with a technique with a balloon. When we deflated the balloon, we gently pushed the catheter inside, and we managed to cannulate deeply in the coronary sinus, and we implanted the reducer. And this patient, 3 months later, had a release of the symptoms. The second case is a case of an ischemic cardiomyopathy. It's a 22-year-old man with previous CABG and has refractory angina and ejection fraction of 40%. He has 2 CTOs in the RCA and the obtuse marginal. We see the angios. He's not eligible for a do CABG, and it's a very high risk to do 2 CTOs operators at once, and a patent lima in the LAD. So we implanted the coronary sinus reducer device. The most interesting part with this procedure was that apart from the ischemia relief, we've seen in the stress EMR, the baseline and 4 months after the implantation, that the ischemia improved and also the ejection fraction increased. Here are the results. The baseline ejection fraction in the MRI was 43, 4 months later was 66, and he improved the ischemia index of MPRI from 1 to 1.3. Also, the strain values from the stress MRI were improved. This was the first patient that was included in a study of 15 patients with ischemic cardiomyopathy that were eligible for reducer implantation to improve symptoms and ischemia. And in this study, we've seen that most of the patients, apart from ischemia relief, from symptomatic relief, reduced the ischemic burden as we evaluated this with an improvement in the MPRI values. So in this patient, we've seen a reduction of the ischemia, improvement of the MPRI, and increase of the contractility. Another study that was published 1 month before, that was very similarly designed as our study, shows the same, that 15 patients that were implanted reducer 4 months after reducer implantation improved in terms of ischemia, and the improvement of ischemia was mainly in the ischemic segments, as we normally see, and also an improvement in with the ratio improving mainly than the subendocardium. And one last case of an ANOCA patient. This is a group of patients that we don't have too many things to do to improve the symptoms. It's a 65-year-old lady with a previous stent in the circumflex, but now he is presented with a refractable angina and has, in the stress MRI, proof of ischemia, a large subendocardial ischemia. We implanted the coronary sinus reducer. We see the cannulation of the coronary sinus with the mother and child technique. Coronary sinus vaginography. We inflate the device. We retrieve carefully the guiding catheter, and this is the final angio. And coming to a conclusion, we've seen in the ANOCA patients in this large study that included 285 patients that symptomatic relief from the angina have patients with advanced coronary artery disease, but also patients with ANOCA. And now these are 2 very promising studies and very well designed that we see, and they proved that reducer improves microcirculation. In this 30 study, they included 30 patients with ANOCA. They divided in 2 patients groups, in endothelium independent and endothelium independent dysfunction. Both groups were improved in terms of microcirculation after reducer. So coronary CFR was increased after reducer implantation, and CBA, coronary blood flow, also increased after reducer implantation. And one, again, very well-designed study to improve how reducer works is this study published in the previous year. This study included patients with ANOCA and refractory angina symptoms, 24 patients in 3 centers in Italy. All patients before were evaluated for microcirculatory resistance that was increased, and 3 months after reducer implantation, we see that the microcirculatory resistance decreased from 33 to 15, and the coronary flow reserve increased after reducer implantation. And these are very promising results on how reducer works and what to expect when we implant in ANOCA patients. So concluding, coronary sinus reducer is a device that has some specific patient group that we can implant. It's until now, the robust data we have is for patients with refractory angina under optimal medical therapy that have no further revascularization options. But some very well-designed studies give us hope for another group of patients, the ANOCA patients. Thank you very much.
Thank you, Dr. Tzanis. Our discussants, Dr. Dardas, Dr. Gabrielatos, Dr. Tsifos, may have a question or comment. Dr. Gabrielatos.
Makuta, can you hear me? Now you can hear me. Congratulations. Thanks for the invitation, Dr. Iakovou. I think that there is an expanding field, this of the coronary reducer, and you showed us about also the microcirculation dysfunction. I think that last year it was the Orbita Cosmic trial that it raised more questions that it gave some answers because there was no improvement at stress myocardial perfusion, but there was a symptom relief in these patients. So I think that we have to define better what does refractory angina means, and we still don't know the mechanism of the improvement that the coronary reducer can offer. And finally, I think that also the concept of no revascularization option should be better evaluated. I don't know how it was done in these studies, if it was a hard team, if there were any CTO operators that they could offer revascularization to a patient like the second one that you showed us, the patient with a previous CABG with a protected lima and 2 CTOs. And the patients that in the previous studies, they were all patients with a good ejection fraction, with an ejection fraction that it was normal. We don't know what happens in these patients with reduced ejection fraction, and if this is the terminal solution for them. Thank you.
Thank you very much. Also a small comment from me. Indeed, the Orbita Cosmic trial was a very nicely study with very good randomization, but the primary outcome was the increasement of the flow in the ischemic segments, and they didn't show any difference before and after reducer. But in the secondary outcomes, it was designed on this outcome, and they reported this. In the secondary outcomes, when they investigated the endocardial to epicardial flow, even though the flow in the ischemic segment didn't improve, the ratio of endocardial to epicardial flow increased significantly. And also in our studies, that's the main message, that we don't have an increase in global perfusion. We see an increase in the ratio from the epicardial to endocardial and from non-ischemic to ischemic segments. So this is a comment that might be better defined in other studies. And to the second comment, the study that was in the CTO patients, it was performed in a study with very high volume CTO operators and very well known, but it was not judged that these patients were ineligible for CTO PCI. We tried to see what we gain from the CTO operator in the CTO operation of high risk in these patients and from reducer. Reducer implantation is a safer procedure. These two patients had increased creatinine levels, so very low GFR. So it was considered more that we might gain the same symptomatic relief with a safer procedure and safer for the kidneys. And that was the reason, not because it was an option for CTO PCI.
I would like to thank you, Dr. Yakov, for this kind of invitation. Thanks, John. And I wonder why this device is not available in the United States now. Maybe we need, of course, a load study shows impressive results, but maybe we need, I think, double-blind some control studies, maybe, for the reason
Yes.
of reducing the risk of bias. I think we need more.
For sure, we need more studies. We have some very nicely designed studies but with few patients that were enrolled. And the United States are always very strict, but we might see in the future.
Yeah. Okay, thank you very much,
Thank
Dr.
you.
Tzanis. We have to move to the next